Welcome back to Rad-On Smart Review, Thoracic Edition. So picture this. You have just cured a stage 3 lung cancer patient.
Always a good day in the clinic.
Right, it's the best. The final fraction is delivered, the bells are rung, the treatment summary is signed, and there is just this palpable sigh of relief in the room.
Oh, absolutely. Everyone is celebrating.
But, and this is a massive but, statistically and biologically, the decision you make in the next 15 minutes during their first post-treatment follow-up visit, well, that could literally be the difference between a durable cure and fatal toxicity.
Yeah, it really could.
We operate under this immense clinical illusion that the heavy lifting is completely finished, and we just, casually hand this patient off for systemic therapy.
It is a totally dangerous cognitive bias. I mean, we really like to think of oncology in these neat, sequential, definitive chapters.
Right, like check a box and move on.
Exactly. Like chemoradiation's chapter 1 and then consolidation's chapter 2. But the biological reality of the tumor microenvironment, and honestly, just the surrounding normal thoracic tissue, it does not recognize those administrative boundaries.
The tissue doesn't care about your schedule.
Not at all. That moment of transition is exactly where the most catastrophic clinical errors originate. Treating that first post-treatment visit as a mere administrative handoff completely ignores the complex, evolving pathophysiology that is actively occurring in the patient's thorax.
So we need to completely reframe how we approach this visit. To anchor this discussion, let's bring a patient into the exam room for you to evaluate.
Let's do it.
We have an adult patient with pathologically confirmed unresectable stage 3 non-small cell lung cancer. It's an adenocarcinoma. They presented with a bulky right upper lobe primary and pathologically involved 4R and station 7 lymph nodes.
Okay, pretty standard presentation.
Yep, and they just successfully completed definitive concurrent chemoradiation. So 60 gray and 30 fractions with concurrent platinum-based chemotherapy.
Got it. So that is a standard, very aggressive curative intent regimen.
Yeah.
I mean, the thoracic tissue has taken a substantial hit at this point.
Exactly. Now, comprehensive molecular testing was sent via liquid biopsy and tissue NGS at the time of initial diagnosis, but the final EGFR status is still pending due to some lab delay.
Which happens all the time, unfortunately.
Right. It's just the reality of practice. So here they are, 4 weeks out from their last fraction of radiation for their first post-treatment assessment. You walk in, and they report substantial fatigue, a persistent dry cough that has definitely worsened over the last 2 weeks, and new resting dyspnea.
Okay, that's definitely a red flag.
Yeah, so you pull up their post-treatment chest CT, and the radiologist has noted a, and I quote, patchy change in the right upper lobe and mediastinum, but no unequivocal distant metastasis.
Well, the clinical reflex here, the immediate temptation for a lot of us, is to just look at that lack of distant metastasis, breathe a huge sigh of relief, and just turn to the medical oncologist to ask when the durvalumab infusion is getting scheduled.
I mean, why shouldn't we? The Pacific trial data is basically etched into our retinas at this point.
Oh, for sure.
We have this 42-day window to initiate consolidation immunotherapy. If they are sitting in your clinic at day 28, the clock is ticking. The instinct is totally to push through, get the drug ordered, and secure that progression-free survival benefit for the patient.
Because doing that entirely skips the fundamental step of risk stratification. I mean, a technically completed radiation course does not prove the patient is physiologically ready for an immune-modulating drug.
Right. They're two totally different things.
Exactly. We have to rely on a strict conceptual framework here to override our completion bias. Every single post-CRT patient must be triaged into one of 3 distinct clinical pathways before any systemic therapy is even discussed.
Okay, so let's get into that framework.
We use the CTR framework. So that's consolidation candidate, toxicity limited, or relapse.
CTR, consolidation, toxicity, relapse. It essentially forces a diagnostic pause. You aren't just checking a box, you are actively categorizing the patient's current biological state.
Precisely. Because a consolidation candidate is fully recovered. They are hemodynamically stable, sitting at their baseline pulmonary function, and genuinely ready for the immune or targeted therapy.
Which our patient currently is not.
Right. And then the toxicity-limited patient is experiencing acute physiological fallout. So that's your pneumonitis, esophagitis, infection, whatever it is that precludes the safe initiation of the next drug. And finally, the relapse patient has suspected or confirmed progressive disease that fundamentally alters the entire curative paradigm.
So applying that to our anchor case, we have a patient actively reporting a new cough and worsening dyspnea at rest. We cannot even look at the C pathway yet.
No, not at all.
They're firmly in the T bucket. We have to manage the toxicity. But When you are standing in front of a patient who is hypoxic and coughing, there is this intense academic urge to pull up the imaging and just start debating the cellular etiology.
Oh, the tumor board special.
Right. You start asking, is this classical radiation pneumonitis? Or is this an early infectious process taking hold in the damaged lobe?
And that academic debate is entirely secondary to physiological stabilization. I can't stress this enough. The unbreakable rule in post-thoracic radiation pulmonary decline is severity first, label second.
Severity first, label second. I love that.
Because I frequently observe clinical teams analyzing the radiographic morphology of a ground glass opacity, zooming in on the scan, while the patient is actively desaturating on room air right in front of them.
Yeah, missing the forest for the trees.
Completely. If a patient presents with new resting dyspnea, rapidly escalating oxygen requirements, a fever, or hemodynamic instability, parsing out the exact cytokine profile causing the inflammation is completely irrelevant in that exact moment.
Right, because the immediate physiological threat is gas exchange failure. You have to secure the airway, initiate supplemental oxygen, and maybe even start empiric broad-spectrum antibiotics and high-dose corticosteroids simultaneously if the presentation is severe enough.
Exactly. You admit them and you stabilize.
And then you can de-escalate and refine the diagnosis 48 hours later once they aren't working so hard just to breathe.
That's exactly it. The precise attribution, whether that hyaline membrane formation is driven by radiation-induced type 1 pneumocyte death, or maybe it's a bacterial pneumonia utilizing the fibrotic scaffolding that can all be differentiated once the patient is actually stable.
Okay, so let's assume we have achieved that for our patient. They are on 2 liters of nasal cannula oxygen, they are resting comfortably, and their vitals are perfectly stable.
Good. Now we can finally look at the imaging to understand the etiology.
So you pull up the report, and the radiologist's impression reads, right upper lobe patchy opacity is consistent with post-radiation change. Now, I feel like the cognitive trap here is accepting that text as a definitive exclusionary diagnosis.
It's huge trap.
It is so incredibly easy to see post-radiation change, mentally file it as expected toxicity, and just close the differential entirely.
Which is a catastrophic diagnostic error. I mean, the phrase post-radiation change in a radiology report is often descriptive. It is not histologic.
Right.
When you are dealing with pulmonary symptoms in the weeks to months following 60 Gray to the thorax, the differential diagnosis remains incredibly broad, and it is highly lethal if you mismanage it. I mean, sure, radiation pneumonitis is common. The ionizing radiation causes direct DNA damage to the pulmonary capillary endothelium and the pneumocytes, and that triggers a massive TGF-beta and cytokine cascade.
Right, which leads to surfactant depletion, edema, and eventually fibrosis.
Exactly. But the timing and presentation of that exact cascade overlap perfectly with several other etiologies.
Yeah, like if this patient had been given induction immunotherapy, immune-mediated pneumonitis would look practically identical on the scan.
Absolutely. You'd see a diffuse ground glass or consolidative pattern driven by CD8 positive T-cell infiltration.
Yeah.
And we also must actively hunt for infection.
Because an irradiated lobe is basically immunologically and structurally compromised at this point.
Totally. The normal mucociliary clearance is destroyed. The radiation-induced fibrosis creates this ideal structural scaffolding for an atypical pneumonia or a fungal opportunist to just take root. And they often do this without the classic lobar consolidation you would expect to see in healthy tissue.
And then you have to factor in the vascular component, too. We just irradiated the mediastinum, we caused endothelial damage, plus the patient has a malignancy, inherently shifting them to a hypercoagulable state.
Right, so you have to think about a pulmonary embolism. A PE presents with dyspnea, tachycardia, and hypoxia, which perfectly mimics radiation toxicity.
Wow, yeah.
Furthermore, any incidental dose to the myocardium, particularly the right ventricle or atria, during the treatment of that station 7 node that can precipitate acute cardiac failure or arrhythmias leading to cardiogenic pulmonary edema.
And lastly, the ultimate fear, recurrent or progressive tumor. An endobronchial recurrence can cause distal atelectasis, or rapid lymphangitic spread can just masquerade as these patchy interstitial infiltrates.
Exactly. Accepting post-radiation change at face value without actively interrogating the underlying data is simply unacceptable practice.
Which brings us to the actual evaluation of that data. I like to frame this through a really specific lens for you listening. Accepting a text-based treatment summary that says 60 Gray delivered as planned, or a radiology report stating expected post-radiation change is functionally identical to buying $1 million commercial property based solely on the Zillow listing.
That is a brilliant analogy.
Right. The photos look great, the summary says the foundation is solid, but you would be utterly negligent to wire the funds without hiring an inspector to physically examine the plumbing, the structural supports, and the electrical grid.
You'd be crazy to just trust the text.
Exactly.
Okay.
In our field, relying on the written prescription and the radiologist's text without opening the raw dosimetric data and performing that inspection is borderline clinical malpractice.
And that inspection requires a very specific, disciplined workflow on the planning workstation. You cannot review the new post-treatment CT in isolation. To determine if a patchy opacity is truly radiation pneumonitis versus a tumor recurrence or an infection, you have to execute what we call the 5-screen review. You need 5 distinct data sets, loaded and co-registered simultaneously.
Okay, so let's execute that inspection on our anchor case. Screen 1 is always the pre-treatment diagnostic CT, often fused with the pre-treatment FDG PET. I am loading this primarily to reorient myself to the native, unadulterated anatomy.
Right, you need to remember what it looked like before we went in there.
Exactly. Where exactly was the bulk of that right upper lobe mass?
Yeah.
Where were the necrotic centers? Which specific nodal stations were hypermetabolic? I need to know the baseline before we altered the architecture.
Perfect. And once you have that baseline, screen 2 is the planning CT. This is the snapshot in time, the exact anatomical geometry on the day we simulated the patient and calculated the physics.
Right.
We need to evaluate the lung volumes on that specific day. Was there baseline atelectasis that we accounted for? Was there a small pleural effusion?
And then screen 3 is where the physics actually overlay the delivered dose distribution. I am not just looking at the target volumes, like the GTV, CTV, and PTV. I am actively interrogating the isodose lines.
Which is where the real story is.
Yeah. Where did the 20 gray lines spill into the normal right lung? Where did the 5 gray line extend? I am pulling up the dose volume histogram, the DVH, to check the V20, meaning the percentage of the total lung volume that received 20 grays or more.
Critical metric.
Because if the V20 was 35%, my index of suspicion for severe radiation pneumonitis just skyrockets compared to a V20 of, say, 15%. I'm looking at the mean lung dose. I really need to know the exact geographic footprint of the energy we deposited.
And then screen 4 bridges the gap between the theoretical plan and the biological execution. Screen 4 consists of the daily image guidance.
The cone beams?
Yes, the cone beam CTs, or CBCTs, acquired by the linear accelerator just prior to beam delivery, because the planning CT was 1 day, but the treatment course was 30 days. You must review representative CBCTs, particularly from weeks 4, 5, and 6.
Because the anatomy in the thorax is highly dynamic, right? If a tumor rapidly shrinks during week 3, the previously compressed adjacent lung tissue might re-expand directly into the high-dose region.
Exactly. Or, conversely, if a massive malignant pleural effusion develops during week 4, it can physically displace the lung and the tumor.
Wow, yeah, so it moves right out of the field.
Right, meaning the high-dose region calculated on the planning CT was actually delivered to entirely different tissue. The original plan on screen 3 is merely the intended map. But the daily CBCTs on screen 4 dictate whether the beam actually stayed on the designated road.
Which finally brings us to screen 5, the new symptomatic post-CRT CT scan. So we have all 5 data sets rigidly or deformably registered to one another. What is the spatial relationship we're really looking for here?
We are assessing the intersection of geography and time. Geography dictates the etiology. Does the new patchy change on screen 5 strictly respect the geographic boundaries of the dose distribution from screen 3?
Because radiation does not care about anatomic lobes.
Not at all. It only obeys physics. If the infiltrate stops abruptly in a straight, unnatural line that perfectly matches the 20 or 30 gray isodose surface, that is a profound radiographic signature of a benign treatment-related effect. It is radiation pneumonitis.
But the biology of a tumor or a pathogen doesn't respect our isodose lines.
Exactly.
If the opacity has a focal, dense, progressively enlarging component that breaches that high-dose boundary and extends deep into lung tissue that only received, say, 2 gray, well, that breaks the geographic rule of radiation injury.
Precisely. A solid, enlarging mass outside the high-dose region raises the immediate suspicion for local recurrence or a distinct infectious consolidation. And then we add the dimension of time. We compare the severity of the infiltrate to the temporal expected timeline.
So what does that timeline normally look like?
Well, grade 2 radiation pneumonitis peaking at 4 to 8 weeks post-treatment is a standard temporal sequence. But if they present with a massive diffuse bilateral consolidation 3 days after the final fraction, The timing does not align with classical radiation fibrosis pathways.
Right, it's just too early.
Way too early. You must pivot toward acute infection, maybe massive immune pneumonitis if they had prior IO or cardiogenic failure.
Okay, so synthesizing this for our anchor case, we do the 5-screen review. The patchy ground glass changes in the right upper lobe perfectly conform to the 30 gray isodose line.
Okay.
There is no focal mass extending outside the field. We consult pulmonology. We obtain a CT angiogram that definitively rules out a pulmonary embolism. Their procalcitonin is negative, making bacterial pneumonia less likely. And we conclude that this is clinically significant symptomatic radiation pneumonitis.
So they are firmly in the T pathway.
Right. So what does this mean for the consolidation strategy?
The actionable mandate is absolute here. You halt the systemic therapy pipeline.
It's completely stopped.
You do not blindly initiate the next systemic step. The introduction of an immune checkpoint inhibitor like durvalumab into a lung that is actively undergoing a massive radiation-induced inflammatory crisis is fundamentally unsafe.
It's adding fuel to the fire.
Exactly. You treat the toxicity first. You initiate a slow, controlled corticosteroid taper. You monitor their oxygenation. You wait for physiological recovery. The primary mandate of the oncologist in this window is to protect the patient from compounding iatrogenic injury.
Okay, let's follow that timeline. We hold the durvalumab. We initiate oral prednisone at 1 milligram per kilogram. Over the next 4 weeks, we slowly taper the steroids. The patient adheres to the schedule, their cough resolves. They are entirely off supplemental oxygen, and their pulse oximetry is 98% on room air.
That's a great outcome.
Yeah, they are feeling energetic again. They have successfully navigated out of the toxicity pathway and have officially transitioned into the consolidation candidate bucket, the C in CTR.
Excellent. Now, the clinical focus shifts to securing systemic control and extending survival. And in the modern era, the bedrock of this pathway for unresectable stage 3 disease following concurrent chemoradiation is the Pacific trial.
Let's really dissect Pacific, because I feel like the trial is often reduced to a simple reflex, post-radiation equals durvalumab.
Oh, all the time.
But the inclusion criteria of that trial represent a highly selected biological state. We cannot apply the survival curves if we don't respect the population that actually generated them.
The population definition is the most critical element here. The Pacific trial enrolled adults with unresectable stage 3 non-small cell lung cancer. They must have completed at least 2 cycles of platinum-based concurrent chemoradiation. But the absolute linchpin of the criteria was that they had to have no evidence of disease progression following that definitive local therapy.
And good performance status, right?
Yes, and they had to maintain a good performance status.
Which is the entire rationale for the post-treatment CT scan we just analyzed so deeply. We aren't merely hunting for pneumonitis. We're actively restaging the thorax and the systemic compartment.
Exactly.
Because if a patient develops a new liver metastasis or local progressive disease during the 6 weeks of radiation, they are biologically distinct from the Pacific cohort. They require an entirely different salvage paradigm.
Precisely. Now, if they met those rigorous criteria, the trial randomized them in a 2-to-1 fashion to receive durvalumab, which is a PD-L1 inhibitor, for up to 12 months versus a matched placebo.
And the biological rationale here is just profound. Radiation therapy is not just a localized cytocidal tool. It is essentially an in situ vaccine.
It really is.
The ionizing radiation shatters tumor DNA, causing necrosis and apoptosis, which basically releases a massive shower of tumor neoantigens into the local microenvironment.
It essentially unmasks the tumor to the immune system. The radiation triggers the CGAS-STING pathway within the tumor cells, driving the production of type 1 interferons, which in turn recruits dendritic cells and CD8-positive T cells right into the tumor bed.
It's amazing. But the tumor fights back, right?
Always. In response to this radiation-induced inflammatory assault, the surviving tumor cells and the surrounding microenvironment upregulate PD-L1.
They basically throw up a stop sign.
Exactly. They throw up a stop sign to those invading T cells, inducing T cell exhaustion and immune tolerance. And that's where durvalumab comes in. It strips away that stop sign. By blocking the PD-L1-PD-1 interaction exactly when the radiation has primed the immune environment, we create this synergistic systemic immune response capable of eradicating micrometastatic disease.
And the clinical outcomes validated that biology spectacularly. I mean, we saw a median progression-free survival of roughly 16.9 months with durvalumab compared to just 5.6 months with placebo.
That is an enormous delta.
Huge in delaying the growth or spread of the disease.
And the overall survival benefit was equally paradigm shifting. The updated analyses demonstrate a median overall survival of nearly 48 months for the durvalumab cohort versus roughly 29 months for placebo.
Wow.
Looking at the 5-year landmark, approximately 43% of patients receiving durvalumab were still alive, compared to 33% on placebo.
A 10% absolute improvement in 5-year survival for stage 3 lung cancer. That is a monumental achievement in thoracic oncology.
It really is.
Ugh.
Crucially, durvalumab also significantly reduced the incidence of new distant metastases, particularly the development of new brain metastases, which, as we know, are a major driver of morbidity and mortality in this population.
The data is completely undeniable. But wait, let's play devil's advocate for a second. Pacific mandated that durvalumab be initiated within a very tight time frame, originally 1 to 42 days post-radiation. In fact, some post-hoc exploratory analyses even suggested that starting the immunotherapy earlier, like within 14 days, might yield an even greater survival benefit, theoretically capitalizing on the peak of that radiation-induced antigen shedding.
Yeah, that data's out there.
So if we have a patient who is coughing, maybe requiring a half liter of oxygen, shouldn't we prioritize that 42-day window? Like, shouldn't we accept a slightly higher risk of toxicity, push through the borderline pneumonitis, and start the durvalumab so we don't squander their chance at a 48-month overall survival?
No, absolutely not. That line of reasoning represents a fundamental distortion of evidence-based practice. You cannot divorce the intervention from the physiological baseline of the patient.
Right.
Initiating a potent systemic immune checkpoint inhibitor in a patient with unresolved hypoxemia, an active undiagnosed febrile syndrome, or an escalating oxygen requirement is not aggressive care. It is reckless care.
Because the patients in the Pacific trial who experienced those massive survival benefits were stable. The trial strictly required adequate organ function and recovery from chemoradiation toxicities.
Exactly. If a patient is actively suffocating from grade 3 pneumonitis on day 35 post-radiation, they are biologically and physiologically excluded from the Pacific population. Administering durvalumab in that setting does not harness synergy. It just compounds toxicity.
It risks accelerating the pulmonary inflammation to a fatal, irreversible fibrotic state.
Precisely. The standard of care is to protect the trial population criteria, not just worship the calendar timeline. Yes, the 42-day window compels us to act efficiently. We should not delay the post-treatment scan due to some administrative backlog. We evaluate rapidly. But the definitive clinical management principle is we respect the temporal window, but we absolutely refuse to sacrifice physiological stabilization to meet it.
That distinction fundamentally changes the risk-benefit calculus. Okay, let's inject a major pivot back into our anchor case. Remember, we were holding off on consolidation for 2 reasons.
Right, the pneumonitis in the labs.
Exactly. First was the pneumonitis, which we successfully treated and tapered. But the second was the delayed molecular biomarker testing. We were waiting on the EGFR status. And the lab just finalized the report today.
Okay, what's the result?
The patient's tumor harbors an EGFR exon 19 deletion. How does this single piece of data redirect our entire therapeutic trajectory?
Oh, it entirely rewrites the consolidation paradigm. The original Pacific trial enrolled without mandating prior molecular stratification. However, when we look at the subgroup of patients within Pacific who harbored EGFR mutations, the benefit of durvalumab was heavily attenuated.
The hazard ratios crossed 1, right?
Yeah.
Now, mathematically, that subgroup was relatively small, so it was underpowered to definitively prove that durvalumab provides 0 benefit to EGFR-mutated tumors.
Correct. We lack the statistical power to make an absolute negative claim based on Pacific alone. However, the biological rationale perfectly aligns with the clinical observation. EGFR-mutated tumors generally exhibit a cold tumor microenvironment.
Meaning they don't have a lot of immune activity.
Exactly. They typically have lower tumor mutational burdens, fewer infiltrating CD8-positive T cells, and their PD-L1 expression is often driven by constitutive oncogenic signaling rather than an adaptive immune response. Consequently, they are inherently less responsive to single-agent immune checkpoint blockade.
That makes biological sense.
But more importantly, we no longer have to extrapolate from a small subgroup because we now possess a dedicated, molecularly selected Phase 3 trial designed precisely for this patient profile, the LRA trial.
Okay, let's anchor you, the listener, to LRA.
The LRA trial enrolled patients with unresectable stage 3 non-small cell lung cancer who possess specific activating mutations, either an EGFR exon 19 deletion or an L858R point mutation. Similar to Pacific, these patients had to complete definitive platinum-based chemoradiation without evidence of disease progression. But instead of an immunotherapy approach, the intervention was targeted. Patients were randomized to receive osimertinib, which is a highly potent third-generation central nervous system penetrant EGFR tyrosine kinase inhibitor versus a placebo.
And the efficacy data from RI is absolutely staggering. The primary endpoint, progression-free survival, demonstrated a median of 39.1 months with osimertinib compared to just 5.6 months with placebo.
A hazard ratio of 0.16.
That's incredible. We're looking at a targeted oral therapy extending the time without disease progression by nearly 3 years in stage 3 disease.
The biological control is profound. Osimertinib effectively penetrates the blood-brain barrier and systemically suppresses the oncogenic driver, significantly reducing both locoregional failure and the development of distant brain metastases. However, we must analyze the data with clinical rigor.
Always.
The overall survival data for RI is currently immature. Furthermore, the trial design allowed for extensive crossover. A large percentage of patients on the placebo arm who experienced disease progression subsequently received open-label osimertinib.
Which muddied the waters.
Yes, this crossover will inherently confound the final overall survival analysis, making it difficult to ascertain if early consolidation osimertinib definitively cures more patients than, say, reserving it for the metastatic relapse setting.
There is also a major difference in the duration of therapy here. Pacific uses a fixed 12-month course of durvalumab. LORI mandates continuous osimertinib therapy until disease progression or unacceptable toxicity.
Right.
So we are transitioning a patient to a chronic, potentially indefinite, targeted therapy.
Exactly. But the most critical takeaway regarding the LRI data is the sequence of events. Let's explore the hypothetical scenario where we did not wait for the EGFR test.
Oh, this is the trap.
Yes. Suppose at day 14, post-radiation, the patient felt well, the test was still pending, and we simply thought, well, the clock is ticking, let's start the durvalumab. If the test comes back positive for EGFR next month, we can always just stop the immunotherapy and switch to osimertinib. Why is that seemingly logical sequence actually highly dangerous?
Because it triggers a devastating biological collision in the pulmonary tissue. The durvalumab has a very long biological half-life. It systemically removes the brakes from the T cells, leaving the lung parenchyma primed with activated hyperreactive CD8 cells.
Right.
If you then introduce osimertinib, a targeted therapy that independently carries a known intrinsic risk of inducing interstitial lung disease and stressing the alveolar pneumocytes, you essentially trigger a system-wide electrical short circuit.
That is an excellent mechanistic analogy. You are stacking toxicities. You have an irradiated lung primed with an immune checkpoint inhibitor, now subjected to a kinase inhibitor that disrupts normal epithelial repair mechanisms.
It's a recipe for disaster.
Truly. The incidence of severe, grade 3 or higher, potentially fatal pneumonitis skyrockets when an EGFR TKI is administered in close temporal proximity following an immune checkpoint inhibitor. The sequence of IO followed by TKI is biologically hazardous.
So, the pending molecular test in our anchor case was not just an administrative delay. It was the ultimate safety and sequencing checkpoint. It determined which of two entirely divergent, mutually exclusive evidence pathways the patient belonged on. Reflexively initiating immunotherapy, while a high-yield actionable biomarker like EGFR is pending, is a fundamental failure of precision oncology.
Absolutely. So let's shift our focus to the third clinical pathway. We have extensively covered toxicity management and the consolidation pathways of Pacific and LOR2. Now we must confront the R in our framework relapse.
CR pathway.
What if our anchor case patient presented for their 4-week post-treatment CT, and instead of a patchy ground glass change conforming to the isodose lines, the scan revealed a discrete, densely solid 3-centimeter progressively enlarging mass located in the lower lobe, distinctly outside the 60 gray high-dose region?
That fundamentally alters the conversation. We must pivot immediately to suspected relapse. But diagnosing recurrence in a thorax that has just absorbed 60 gray is notoriously complex.
It's a mess in there.
Yeah, the irradiated lung is this chaotic radiographic landscape of acute inflammation, resolving atelectasis, dense fibrotic scarring, and potentially a residual necrotic tumor. We cannot take one equivocal post-treatment CT and definitively declare biological failure. We need serial imaging and often functional modalities.
Which invariably leads to the reflex order of an FDG-PT CT scan. The clinical urge is to use a PETA scan to just cut through the anatomical distortion, right? Like, let's just see if the mass lights up.
Right.
But we must understand the cellular biology of irradiated tissue. to understand why PP is not a magic wand in this specific window.
Because the primary mechanism of FDG-PT relies on the Warburg effect, the rapid uptake of glucose by metabolically active tumor cells.
Yeah.
But the problem is that tumor cells are not the only entities in the thorax consuming glucose post-radiation.
Exactly. Radiation induces massive tissue injury. In response, a vast army of inflammatory cells, predominantly macrophages and neutrophils, infiltrate the irradiated field to clear necrotic debris and initiate tissue repair.
And they are hungry.
Very hungry. These activated macrophages massively upregulate their own GLUT transporters. They become hypermetabolic, voraciously consuming the radio-labeled FDG. Therefore, a PET scan obtained within the first 3 to 6 months following definitive chemoradiation will frequently demonstrate intense, glowing, widespread avidity throughout the treated volume, entirely driven by benign inflammatory macrophage activity.
So, relying on the SUV max, the standardized uptake value to differentiate residual tumor from radiation fibrosis in that acute window, is essentially a coin toss. It has a staggeringly high false positive rate.
It really does.
A glowing mass on a post-treatment PT is absolutely not definitive pathologic proof of local recurrence.
Therefore, we deploy FDG PT-CT not as a default surveillance tool, but as a highly targeted problem-solving modality. We use it to answer specific questions like, does this new morphologically concerning mass outside the primary radiation field also demonstrate hypermetabolism? Or is there evidence of occult distant osseous or hepatic metastasis that would entirely preclude a local salvage attempt?
Right, it's about problem solving. And because of that inherent inflammatory false positive rate, whenever it is anatomically safe and clinically actionable, obtaining definitive tissue confirmation, a biopsy, remains the gold standard.
Always.
We don't biopsy everything. We choose the safest, highest yield site that will categorically change our management strategy.
However, before we can even begin to debate the optimal multidisciplinary salvage strategy for a confirmed recurrence, we must actively triage for impending clinical urgencies. A recurrent tumor in the thorax is a highly destructive entity.
Yeah, it's not waiting around.
If the recurrence is compressing the superior vena cava, resulting in SVC syndrome, or if there is an endobronchial recurrence causing severe airway compromise, or if the tumor has invaded a major vessel causing massive hemoptysis, or if a new metastasis is threatening spinal cord compression, the academic debate regarding systemic therapy sequences immediately ceases.
You don't present a patient with massive hemoptysis to a tumor board to debate the nuances of salvage immunotherapy. You act.
You intervene immediately.
Airway stabilization, interventional pulmonology for rigid bronchoscopy and stenting, vascular embolization, or urgent, highly targeted palliative radiation. You secure the patient's immediate survival before you finalize the staging narrative.
Assuming there is no acute emergency, let's explore a scenario that frequently traps eager clinicians. Suppose the recurrence is isolated, non-emergent, and located directly adjacent to or partially overlapping the previous radiation field. The patient is healthy. The immediate instinct is to consider a second course of thoracic radiation.
Rear radiation.
Yeah.
And here's the trap I see constantly. A clinician looks at the new CT scan, identifies the local recurrence, and then pulls up the text-based treatment summary from the first course. The summary reads, primary tumor received 60 grays in 30 fractions. Spinal cord max dose 42 gray. The clinician does some mental math, realizes the spinal cord can generally tolerate around 50 gray, estimates the geometric distance on the new scan, and concludes, well, we have 8 grays of spinal cord tolerance left, let's just re-irradiate the mass.
Oh, that mental math is a lethal proposition. A text-based written prescription summary cannot, under any circumstances, capture the three-dimensional dosimetric reality of a delivered radiation plan.
It's just physically impossible.
When a summary states cord max 42 gray, it provides zero geometric context.
Right. Where on the spinal cord was that 42 gray deposited? Was it a pinpoint dose at the T4 vertebral level? Or was it a broad swath of dose spanning from T3 to T7? Is the new recurrent tumor located at the exact same level? How rapidly did the dose fall off laterally from the spinal canal?
You cannot extrapolate a 3D dose gradient from a single number. To even contemplate thoracic re-radiation safely, you must possess the complete prior digital dosimetric record.
The full DICOM file.
You must retrieve the original planning CT DICOM files. You need the specific structural contours drawn by the previous physician to understand their anatomical definitions. You require the full 3D dose matrix, the voxel by voxel distribution of energy, and ideally, the daily CBCT imaging to understand the delivered setup variations.
And once you have that data, you don't just eyeball it. You rely on advanced physics. You perform rigid, or more often deformable, image registration, mathematically warping the old anatomical scan onto the new patient anatomy to calculate the precise cumulative dose that any given millimeter of the spinal cord, esophagus, or major vessel has received and will receive.
Improvised cumulative dose estimates based on a text summary are the direct route to catastrophic fatal toxicities.
Like radiation-induced myelopathy leading to paraplegia?
Yes, or esophageal necrosis, or massive, uncontrollable fatal hemoptysis from a major vessel blowout. Reirradiation is a highly specialized, technically demanding multidisciplinary endeavor. It requires the actual dosimetric blueprints, not just the receipt of treatment.
That is a stark, necessary warning. So moving past the acute phase, let's assume the patient navigates the toxicity, successfully completes their consolidation with durvalumab or osimertinib, and transitions into long-term surveillance.
The maintenance phase.
Right. The anxiety doesn't disappear, it simply shifts. What is the evidence-based framework for monitoring these patients to catch these recurrences early?
Post-treatment surveillance should be rigidly CT-based. While subtle variations exist among major societal guidelines, a standard, robust framework involves a chest CT with intravenous contrast every 6 months for the first 2 years, transitioning to an annual basis thereafter.
Some places scan more often, right?
Yeah, some high-risk institutional protocols advocate for scanning every 3 to 6 months for the first 3 years. The critical element is adherence to a standardized, non-arbitrary schedule.
And equally important is defining what we explicitly exclude from routine surveillance. We have already established the inflammatory false positive rate of PETT. Therefore, routine asymptomatic surveillance with FDG PTCT is strictly contraindicated.
Yeah, do not order them.
If a patient is clinically stable and their chest CT shows stable fibrotic changes, ordering a PET scan simply for reassurance will inevitably yield incidental inflammatory uptake, generate profound patient anxiety, and cascade into unnecessary high-risk invasive biopsies.
Exactly. And similarly, routine brain MRIs are not indicated for asymptomatic surveillance in the standard stage 3 population following completion of definitive therapy, unless the patient develops new focal neurologic deficits or they possess a highly specific risk profile that warrants targeted intracranial screening. We lean on the anatomic data of the chest CT.
But there is a crucial clinical philosophy underlying this surveillance schedule. Surveillance is an active, dynamic assessment, not merely the passive collection of images for a database.
That is the most important clinical pearl of the follow-up period. At every single visit, you are not merely reading a radiology report. You must critically evaluate the patient sitting across from you. You have to ask yourself, what is the biological reserve of this patient today?
Right, because things change over 2 years.
If a patient has physiologically deteriorated over the last 2 years, if their performance status has plummeted due to advanced age, severe COPD exacerbations, or cardiac failure, to the point where they could never physiologically withstand surgical resection, complex reirradiation, or aggressive salvage chemotherapy, then the fundamental logic of aggressive radiographic surveillance collapses.
Exactly. If finding a 1 centimeter asymptomatic recurrence would not change your management because the patient literally cannot tolerate the treatment, then the scan serves no medical purpose. A surveillance schedule without a viable, executable therapeutic response plan is not a medical strategy. It is just an engine for generating anxiety.
I completely agree. You must continually align the intensity of the surveillance with the physiological capacity of the patient to endure a salvage intervention.
Okay, let's synthesize these complex pathways into highly actionable, board-relevant logic. We are going to integrate these concepts into clinical hypotheticals, the exact type of scenarios where clinicians frequently stumble. Let's walk through 3 specific traps.
All right, hit me.
Scenario 1. You are evaluating a patient 4 weeks post-CRT. They feel great. The CT shows no progression. The clinician immediately states, the CRT phase is over, so the definitive next step is to order the durvalumab infusion. Where did they go wrong?
The fatal flaw in that logic is reflex prescribing without explicitly executing the classification step. It is an unsafe response because it entirely ignores the molecular status.
Right, they skipped a step.
The corrective action, the sophisticated clinical approach, is to verbally establish the framework. I am evaluating this patient for the consolidation pathway. They were physically recovered and imaging confirms no progression. However, before I initiate immunotherapy, I must confirm their EGFR molecular status because initiating durvalumab in an EGFR mutated patient prior to a TKI is biologically unsafe and suboptimal. You prove that you are analyzing the biology, not just following a timeline.
Excellent. Okay, scenario 2. A patient presents with a new vague opacity on their post-treatment CT. The clinician looks at the single scan and declares, "This opacity is radiation pneumonitis. Start steroids."
That is the trap of binary false certainty based on a single radiographic snapshot. Because radiation injury, opportunistic infection, immune-mediated pneumonitis, and tumor recurrence can all overlap geographically and temporally in the irradiated thorax, a single scan is rarely definitive.
So what's the better response?
The sophisticated reasoning requires you to state, I see the opacity. I will integrate the severity of the patient's hypoxia, the temporal relationship to the end of radiation, and I will perform the 5-screen dosimetric review to see if the morphology conforms to the 30 gray isodose line. I will also evaluate for infection before committing to high-dose immunosuppression.
Perfect. Scenario 3. A patient has a confirmed local recurrence. The clinician says, "I reviewed the written summary. The cord max was 42 gray. We have room to re-irradiate this new mass."
Well, we have dissected the physics of why this is lethal, but the actionable takeaway is absolute here. A written text summary is mathematically incapable of reconstructing the delivered 3D dose gradient. The required clinical action is to halt the discussion and state, re-irradiation cannot be safely evaluated with a text summary. I will retrieve the full prior DICOM dataset, the planning CT, structural contours, and 3D dose matrix, and perform a deformable image registration to calculate the exact cumulative dose to the spinal cord before I offer a salvage plan.
Incredible. Finally, let's run a rapid-fire clinical blitz to lock down molecular pathways for our listeners. Case A patient is post-CRT, no progression, excellent performance status, fully recovered. Molecular testing confirms they are EGFR wild type.
They perfectly match the Pacific trial inclusion criteria. The optimal management, assuming no autoimmune contraindications, is to initiate durvalumab consolidation for up to 1 year to secure the established overall survival benefit.
Case B, exact same clinical presentation. Recovered, stable, no progression. However, the molecular testing returns positive for an EGFR exon 19 deletion.
The pathway immediately shifts. You do not blindly sequence immunotherapy. This patient's biology aligns with the LORARE trial. The recommendation shifts to initiating osimertinib consolidation therapy, leveraging the targeted kinase inhibition to secure the profound progression-free survival benefit demonstrated in that specific molecular subset.
Got it. Casey patient arrives for their 4-week post-CRT visit. The CT shows a new opacity that does geographically overlap with the high-dose 60 gray treatment field. However, the patient is febrile to 102 degrees, hypertensive, and the radiologist notes that within the overlap there is a dense, focal, centrally necrotic mass.
You immediately abort any consolidation plans. Geographic overlap does not guarantee benign etiology. The fever and hypotension strongly indicate a severe infectious process, and the necrotic mass raises the distinct possibility of rapid local failure. You must admit the patient, stabilize their hemodynamics, obtain blood cultures, and involve interventional pulmonology for a potential bronchoscopy to differentiate infection from recurrence. You do not initiate durvalumab or osimertinib in an unstable, undiagnosed patient.
This has been an incredibly dense, mechanistic exploration of the post-treatment window. I mean, we have covered the cognitive biases of the administrative handoff, the cellular biology of pneumonitis, the complex physics of the 5-screen dosimetric review, the exact biological populations of Pacific and LoRa, and the extreme hazards of text-based re-irradiation. As we conclude, what is the final fundamental principle you want to embed in the minds of the clinicians listening today?
I want every clinician to internalize this biological reality, the most advanced, targeted, multi-million-dollar systemic therapy in the world, whether it is an immune checkpoint inhibitor or a third-generation kinase inhibitor, is entirely useless if you administer it to a patient who is actively suffocating from an unrecognized, reversible pulmonary toxicity.
Wow, yeah.
Your primary duty as an oncologist in the acute post-radiation window is not merely to prescribe the next novel drug. Your mandate is to rigorously protect the patient's curative intent by knowing exactly when the biology demands that you hit pause.
Protect the curative intent by respecting the biology, not just the calendar. What a way to end. Get show notes and complete practice oral boards at radonsmartlearn.com and subscribe for our next review. Thanks for tuning in.